In most cases, once the preconditions have been met, the diagnosis of death using neurological criteria can be safely and accurately made using clinical criteria alone, without the need for any additional investigations. In the hands of experienced clinicians, the bedside clinical tests we have described will safely confirm death with the confidence and accuracy demanded for this important diagnosis. There are, however, a few occasions where the use of an ancillary investigation may assist with the clinical diagnosis of death, confirming that all brainstem function has been irreversibly lost. For example, if clinical examination is made difficult by extensive faciomaxillary injuries, it may not be possible to examine all of the brainstem reflexes. A high cervical cord injury at the origin to the nerve roots that comprise the phrenic nerves may complicate or indeed invalidate interpretation of the apnea test. Perhaps the most common source of concern is where the continued effects of residual sedation cannot confidently be excluded. There are a number of ancillary investigations that can be used to assist in the diagnosis of death using neurological criteria. They must always be used in addition to clinical testing, carried out to the fullest way possible in the circumstances, and should never replace it. The diagnosis of death always remains primarily a clinically based procedure. The ideal investigation is one that is easy to undertake, universally available, easy to interpret, and has no false negative or positive results. Currently, no single investigation meets these stringent requirements, though some are closer than others. There are three main types of investigations: imaging, neurophysiological, and pharmacological, otherwise known as the atropine test. Cerebral angiography with arterial catheter or by CT can be used to demonstrate absence of cerebral blood flow. CT angiography is widely available in most hospitals, but needs to be reported by a radiologist familiar with the technique. An experienced radiographer is required to perform the scan using a specific protocol, such as that described by FRAMPAS. This protocol specifies the timing of injection of the contrast medium and acquisition of the images. Contrast must be seen in the temporal arteries at 20 seconds to confirm that the dye has been successfully injected. The third phase at 60 seconds is used to look for the absence of contrast in cerebral arteries and lack of flow in internal cerebral veins. CT angiography is not perfect. In some 15% of cases of death confirmed using neurological criteria, some blood flow has been seen in the proximal cerebral arteries, the significance of which can be difficult to interpret. Four-vessel catheter angiography is more invasive and less widely available. Radionucleotide scanning can be performed with technetium-99 injection. No uptake in the brain is seen in death diagnosed using neurological criteria. This investigation is not widely available. All these investigations have the disadvantage of needing to move the patient to the X-ray department. Transcranial Doppler ultrasound has the advantage of being a non-invasive bedside technique, but it does need to be carried out by personnel very experienced in the technique. The aim is to look for absence of pulsatile flow in cerebral arteries. The lack of general availability and the need for very experienced operators make this test less viable for most centers. Electroencephalography, or EEG, can be used to support a diagnosis of death by neurological criteria. For this, an isoelectric EEG trace is required and should demonstrate complete lack of reactivity to intense somatosensory or audiovisual stimuli. This needs to be performed by a technician trained and familiar with the technique. Persistent sedative drugs, which suppress cerebral electrical activity, may make this investigation difficult to interpret, and some have suggested it should not be used for this purpose. Finally, there is also a simple, universally available pharmacological test that can be helpful. An intravenous injection of 2 milligrams of atropine is administered. If the heart rate does not rise by at least 3%, this suggests lack of vagal activity due to dysfunction of the caudal brainstem. This supports the diagnosis of death by neurological criteria. This test should only be done after the completion of clinical tests to avoid affecting the pupillary reflexes. This test is best considered an adjunct to clinical testing rather than a confirmatory test in its own right. So in summary, there are a number of investigations that should be seen as ancillary and supportive of clinical testing for death using neurological criteria. They should only be used where there are limitations to clinical assessment and testing and never used on their own. None of the investigations meet the criteria of the ideal test, and they all have advantages and disadvantages. Availability of tests will vary from centre to centre, and if the clinician chooses to use a test, they should take this factor into account in their choice. From the options available, CT angiography in experienced hands will probably be the investigation of choice for most hospitals.